So I had the opportunity to kind of attempt to summarize the afternoon sessions from yesterday. I do. So I'm going to summarize some more information from the opportunities for barriers to treatment and prevention. Okay. So I started with the talk of Dr. Nora Englander from Oregon Health Sciences University, focusing on improving care for hospitalized adults with substance use disorder. She stated what we are seeing in terms of the dramatic increase in opiate-related hospitalizations and the associated expenditures, and argued that hospitalization is a reachable moment. While our traditional approach was kind of characterized by one of the quotes from a surgeon with whom she has worked at, we are typically running around with buckets trying to fix a leaky roof. That has been our traditional approach. We do know that this is an opportunity to reach those not already engaged in care. Majority of patients actually want help changing their substance use disorder and actually want medication to start in the hospital setting. With her impact team, a multidisciplinary service that looked at rapid access pathways to community treatment, they've been able to demonstrate increased patient engagement and linkage, improved provider morale, decreased inpatient length of stay, and again, as was mentioned previously, highlighted the values of peers. Peers have been working in outpatient setting, but highlighted the values of peers in the hospital setting and emphasized that this may require a cultural shift in terms of working with HR and legal in terms of being able to employ peers in the workforce in this setting. My biggest takeaway point from her presentation was that substance use disorder treatment in the hospital should be the standard of care. And lastly, from her talk, learned that we have the ability to learn from our failures. So she talked about the MERT model, the medically enhanced residential treatment model, where they made an effort to integrate IV antibiotics into the residential treatment setting and ultimately ended up with poor recruitment and poor completion. But through that failed intervention, highlighted the importance of the patient voice in terms of when we're looking at implementing interventions, we need to have the voice of the patient and patients from across the spectrum, so from all stages of change. So those who are in pre-contemplative phase and those who are in remission and active recovery. The treatment pathways need to span the hospital and community settings, and we need to have new models that have the potential for iterative designs. From Dr. Zoller's talk, the Southern Sendemic, Poverty, Opiates, and Infectious Diseases, we realized that highlighted that HIV is a symptom of a broader ill, poverty. So anywhere from 1/2 to 2/3 of the poorest counties in this are located in the South, and similarly, greater than half of all new HIV infections in 2016 located in that same distribution, in an area where the continuum of care is lacking. So from prevention all the way through treatment. So just an example, less than 1/3 of all PrEP users were in this same geographic area where you have greater than half of the new infections. And what he also highlighted is that this was not limited to HIV. Similarly, you can find similar statistics for hepatitis C. He talked about an impending tidal wave. So historically, the South has seen lower rates of opiate use. However, they're starting to see an increase in treatment admissions. There's also data to suggest higher rates of misuse or non-medical use of prescription opiates. But this is an area that has limited resources and are less prepared to deal with this impending tidal wave. Few treatment providers and even less or a paucity of harm reduction services. Again, the high rates of opiate prescribing, still dealing with substantial stigma and potentially hostile climate. And he also noted notable gender differences in that the increase in prescription of opiates for women and high rates of actual overdose deaths in this region for women. In terms of the example, the Arkansas example, he talked about kind of going where the resources are, where the patients are, and also where the resources are. How the county jail system had actually expanded resources, and so that's where he went and just initiated engagement with the criminal justice system in the county jail, started doing surveillance of opiate use disorders, assessment of HIV risk disorders. And in terms of next steps, linking to PrEP upon release, expanding treatment, or actually initiating treatment in correctional institutions and primary care. And then what I took from the discussion that followed this session was we need to be looking at, again, other models. So telemedicine, and then also, as was mentioned previously, we need to look at global health initiatives. So look at our international partners who are doing some really remarkable things in resource-poor areas and potentially adapting some of those things to our resource-poor areas here in the United States. In terms of the infectious disease and the opiate epidemic correctional health, Dr. Jody Rich from Brown University just reminded us again, I think I'm preaching to the choir here, but we just want to remind people again that addiction is a chronic brain disease that's manifested by compulsive drug seeking and cycles of remission and recurrence. There are both genetic and environmental factors that contribute to addiction, and opiate use is characterized by tolerance and withdrawal, and it's this cycle that perpetuates the continued use of opiates. Precipitous rise in criminal justice population corresponding with our war on drugs. So it's estimated that annually 10 million people are cycling in and out of the criminal justice system. There are marked racial disparities in terms of who's entering and who's arrested, who's convicted, and then even the length of sentences, sentencing disparities. Still exist. Large proportion of inmates have substance use disorder, and their overlapping social determinants of health. Substantial proportion of ID burden or infectious disease burden also passing through the correctional system. So you've got both epidemics in the same population. And then based upon the Rhode Island experience, implementation of routine screening and initiation of medications for addiction treatment in the correctional system, including access to all 3 of the FDA-approved medications and linkage to treatment, found remarkable 12% reduction in overdose deaths in the state, looking in for the 6 months before and 6 months after. So my takeaway is that medications for addiction treatment saves lives, and this is what we should be doing. In terms of Dr. Linus's talk, in terms of the value-driven priorities for addressing the opiate epidemic, he gave us a primer on cost-effectiveness research that I thought was actually pretty unique. I am not one who can usually grasp economic principles very well, so I thought he did a great job of just reminding us, first of all, that cost-effective research, the goal is to maximize outcomes, not save money. And it can be used, this type of research can be used to guide our priorities in areas and in settings where we have limited resources and also lack of political will, but also cost-effective does not necessarily mean affordable. When we look at specific infectious diseases, so specifically for hepatitis C, testing for adults 18 years and older is high-value, cost-effective intervention, as is treatment, a high-value, cost-effective intervention, and it should not be restricted in persons who are injecting drugs. When we move to HIV, MAT represents the greatest benefit and is HIV prevention. So I know that there's increased emphasis on prescribing of PrEP, but when he showed that curve, PrEP was actually on the flat end of the curve, and the greatest slope was for medications for addiction treatment. So again, this speaks to the ability of medications to save lives and reduce transmission. When we looked at, there's less data on other infectious diseases associated with the opiate epidemic, so less data on endocarditis or other skin and soft tissue infections. However, hospitalizations are becoming more frequent and costing more money, and this is a ripe area for study. And in fact, he has a colleague who's going to be doing this as part of their K award. He left us with one potential caveat in terms of the accountable care organizations that are designed to kind of reduce fiscal expenditures by having capitated payments, and the concern that we just need to be vigilant about the potential exclusion of patients with substance use disorders because they are patients who are going to have higher expenditures and greater higher utilization and greater expenditures, and we just want to be mindful that these patients are not being excluded from these entities. And then from the discussion take-homes, from the discussion that followed, so Dr. Springer talked about her work with extended release naltrexone prior to reentry, and was able to demonstrate improved HIV viral suppression 6 months post-release in HIV-positive prisoners. There was a debate about the additional benefits of counseling, and there have been some studies that have not demonstrated additional benefit. However, it was stated that medication is not going to address the trauma, is not going to address the coping skills. But we don't want the requirement for counseling to be a barrier for expansion of medications for assisted treatment. And so we've got to look at both of those issues, but we don't want it to be a barrier. We don't want anything to be a barrier to expansion of what we know as evidence-based treatment. There was a discussion about eliminating the buprenorphine prescriber limits, with the caveat that if we're doing that, we want to make sure that we're ensuring high-quality prescribing. We talked about the training gap for addiction treatment, and there was a talk about we need more infectious disease clinicians to be treated, but also it can't be limited to just infectious disease clinicians. It needs to be primary care providers, internists, family medicine, emergency department providers. We need to look at our undergraduate and graduate medical education, and then again, we need to not have a narrow view of the workforce. We need to include our colleagues in terms of nurse practitioners, PAs, pharmacists, certified nurse midwives. Everybody needs to be working together to address this epidemic. And then finally, the last thing that I took home is that we need comprehensive system-level interventions.